Welcome, everybody. This is the fourth webinar that we've done in an opioid related topics. And we do have a small group today. We had about 38 people register, but so far we only have about 6 or 7 of you that are attending, and maybe more will join us. So the nice thing about having a small group is that we have time for lots of interaction and can kind of open up the phone lines a little bit easier. So I'll go ahead and kick us off. My name's Amber Rogers, and I'm with Mountain Pacific Quality Health. And we're putting together this long-standing opioids session. You will all have to register for these events one at a time because they vary in dates and times that we offer them. So with no further ado, I'm gonna kick this off to Dr. Sutherland, and I'll give him a brief introduction quickly, and then I'll do one more slide, and then I'm gonna turn it over to him. So Dr. Sutherland actually graduated from with his PhD in clinical and child psychology from the University of Virginia, and is licensed as a psychologist in Montana and New Mexico. Who knew? I didn't know that, Earl. He has worked as, he's board certified in medical psychology and has lots of clinical as well as administrative work in schools, child advocacy centers, community health centers, private practice, and general and psychiatric hospitals, as well as Indian Health Services. So I am pleased to work with Earl on a routine basis and have appreciated his knowledge in this area and wit. So with no further ado, I'll forward. So I just wanted to let you guys know, we did ask some polling questions at the start of the, when you registered, and about 32% of you have already implemented medication assisted treatment in your clinics. So that is awesome, and thank you. So we hope to hear from some of the people that are more experienced in this to help those that aren't. In addition, we asked you some specific questions about areas that you needed help with. And Earl will go through some content, and then he is answering those questions towards the end. So stay tuned. And now I will turn it over to Earl.
Thank you. I have extensive experience, which means that what I can offer you is a great deal of learning because I've probably been around long enough to mess everything up and have learned many things the hard way, which often results in being able to save other people some time. And that's what I'd like to accomplish today in terms of goals, is to share with you some general information in terms of why this is worth doing, present the information in terms of a return on investment for folks, and then, as Amber said, to answer specific questions. That we have a small number of people is great. I think that will hopefully lead us into being able to have a dialogue and an actual conversation, as well as sharing the mutual information that we have with each other. Next slide, please. This is just the definition that you'll find from the FDA. It looks like almost a third of the folks who signed up for this have implemented MAT, so you may be very familiar with the definition. For those of you who aren't, that's why we put it up here. Next slide. We probably are most familiar with MAT in terms of its use for opiate use disorder, but I want to remind people that there are also effective medications that we have with a strong evidence base for treating alcohol use disorder. Unfortunately, we don't have anything equivalent to buprenorphine for stimulant use disorder, so meth and the treatment of folks with amphetamine or stimulant use disorder remains lacking in terms of options for medications that we can use. One of the things that I'd like to call your attention to is that third line down, block the euphoric effects of alcohol and opiates. Um, Hopefully you've had some presentations on the neurophysiology of the addictive process and the cortical and subcortical structures, but it's essentially the euphoric effects that make this a chronic illness and so hard to deal with. So when we get the opportunity to block those, and in particular to be able to block the receptors that are integral to opiate use disorder and the addiction process that goes with that, we really have some fantastic tools that we can bring to bear in treatment. Next slide, please. So this is a list of the medications commonly used in terms of diagnosis. So for alcohol use disorder, we have 3 major medications with a strong evidence base. Then in opiate dependency or opiate use disorder, buprenorphine or buprenorphine or bup, methadone and naltrexone are approved. Methadone has been around the longest. We have extensive research on that. And if you've gone through the waiver training, you're familiar with what getting a waiver actually means, which may be a little counterintuitive at first, but there is actual federal legislation that prohibits the use of an opiate in the treatment of opiate use disorder. And so by qualifying through the training that's available, you obtain a waiver, which then authorizes you to use, for example, buprenorphine in the treatment of opiate use disorder. Naltrexone is not an opiate, so there's no waiver required for that. Next slide, please. So I want to give you some brief overview. If you're already familiar with that, that's great. I would like to reinforce what I hope you're already aware of, that the opiate epidemic actually has been an epidemic that is creating great problems. And while we're legitimately facing overwhelming problems with the COVID-19 epidemic, we still have the opioid overuse and the death rate continuing in the same pattern that it was before. The good news is we have made some significant difference in things. The catch in terms of the data is that we tend to run about 2 to 3 years behind getting the most recent publicized data. So that's why the most recent data available is 2018. Next slide, please. This is the overview of what's happening in Montana. The key at the bottom gives you the color coding. Generally, the darker the color, the greater the preponderance of overdose deaths. The distribution is by population, which makes sense. Wherever we tend to have more people, we tend to have more illness, and we tend to have more deaths by overdose associated by the greater incidence of population. Next slide, please. And this is the good news, bad news variation on what we've seen happening. If you take a good look at this chart, and I hope it shows up large enough on your small screen so that you can see it, but we started to see an increase, and you will see down at the bottom of the chart, wave 3, which is the darkest coloring, and that represents the onset of synthetic opioid overdose deaths, and most specifically fentanyl, carfentanil in particular. So we had a great deal of attention, a massive investment in energy and resources to start to deal and offer treatment for opioid use disorder. And we started making some progress. And then along about 2015, And the acceleration, as you can see from this, started before then, but then we crossed in terms of the diminishing good news about overdose deaths, and then with the onset and unfortunately ready availability of synthetics, and again specifically fentanyl and carfentanil, we started seeing a dramatic increase in overdose deaths because of those substances. Next slide. I want to call your attention to, on your right, the heroin use has increased among most demographic groups. If you look at that chart closely, there's some alarming information. This is from 2014, so I can't find the equivalent of this breakout more recently than that. But if you look at increase in use by age, and then also look at ethnicity and gender, what really jumps out at you is that in this chart in particular, the heroin use increase really happened for folks during their prime parenting years. We were in danger of wiping out an entire generation of young adults, and specifically parents, in a very alarming rate. The heroin increase, unfortunately, is the predictable process that we've seen, that once you get into mass marketing, whether it's a legitimate enterprise or an illegal enterprise, the same principles occur. So we've had cartels taking over the production of heroin, and instead of it being confined to the Golden Triangle, there are now poppy fields across the world, large increase in South America, Central America. The decline in heroin is another one of those bad news, worse news, in that seems to be declining, but that's because we now have fentanyl mass produced, and it actually has become cheaper. Next slide. So the other information that some of you may be aware of is that there's a cost to SUD in terms of business, and that's what I want to review briefly for you. We often get to see the data on overdose deaths. We get to see the data increase in use, but I want to spend just a few minutes going over this is what substance use disorder affects in terms of our economy, and specifically in Montana, to productivity and the cost of business. So keeping in mind that in Montana, alcohol, meth, cannabis, and opioids in that order are our most frequently used substances, we have really a reality that is polysubstance abuse, not a specific substance. So having an individual use only one substance of misuse is very, very rare. Those of you who have been in the substance use disorder field and treatment are familiar with the term a unicorn, and in this context, the unicorn is an individual who had one predominant substance of misuse. We have polysubstance abuse is the reality of what we deal with. I want to call your attention to that last bullet point, which is 80% of drug users support their use by stealing from work. We often think that, it's someone doing burglary, but for many cases, it's the easiest access to things that can be marketed or sold to purchase drugs is what's going to happen most often. Next slide. I want to call your attention to the first point, which is that 16% of ER patients at work have alcohol in their system. And that's really alarming, because we have people being intoxicated or being under the adverse effects of substances at work. Work also is something to keep in context. So you may be aware that the two Occupations with the highest occupational injury rate are farming and ranching. And so for our rural areas, to have impairment while you're engaged in farming or ranching means a higher likelihood of significant accidents in terms of severe bodily injury and harm, and also a higher incidence of fatalities. So if we add substances to farming and ranching work, we are taking the two um, arguably most dangerous occupations and making them even more dangerous. Withdrawal symptoms is something that often is not appreciated in terms of what that effect is. So many people are familiar with the alcohol withdrawal and the life-threatening incidence of seizures in that. Opioid use withdrawal is not as fatal in the same sense that alcohol withdrawal can be. But I'd like to suggest you think in terms of withdrawal occurring multiple times, as in I am not able to access the substances that I rely on to stop withdrawal, and may go days without that, and then obtain the substance to again stop the phenomenon of withdrawal and stabilize, but then that starts all over again when I'm not able to obtain that. In the use of opiates, and it depends on the formulation and the type of opiate, but you can have withdrawal starting and onset, for instance, within 6 to 8 hours. Um, so if you are able to maintain that steady state, or at least forestall withdrawal, but for whatever reasons can't get the next dose or the next intake of use, then that starts. And that leads to the third point, which is inability to focus or concentrate while under the influence. Along with that is an impairment in your motor function, depth perception. So that sequence of withdrawal once, twice, 2, 3 times a week now should suggest that, there are many more problems than we perhaps initially realize in substance use disorder and in our workforce. Next slide, please. And this is really an indication of what percent that we might just in general consider in terms of the number of employed adults who may be experiencing substance abuse or substance use disorder in their family. And then this is the percent of employees who in the survey that is the origin of this data expressed their concerns or their beliefs that their productivity suffered as a result of that. Back on that first bullet point, the other thing that you may be aware of is that it's not the stranger who accosts you on the street offering to sell you illegal substances. The largest supplier of illegal substances, and especially in terms of prescription medications, is a family member. Not to suggest that family members are selling their legitimately prescribed medications to other family members, but it's a case of access. Knowing that Uncle Earl has medications for his pain and you know where they're kept means that you probably know how to have easy access to them, or at least access, whether it's easy or not, to substances that are critical for you to avoid experiencing withdrawal. Next slide, please. This is some updated information. Hopefully you're already aware of it, but I wanted to put this in just to emphasize that SUD continues to be ongoing. And even though we are now, as I mentioned earlier, facing the COVID crisis, individuals with substance use disorder really are at much higher risk. So although they're about 10% of the population in the most recent study, they were almost 16% of the COVID cases for severe responses and severe presentations of the illness. So it comes down to, if you've got a substance use disorder, You're more likely than the general population to develop or to become infected with COVID. The strongest effect in this particular study was for opiate use disorder, then followed by tobacco use disorder. And then not only are you more likely to become infected, you're more likely to have a worse course of illness and more severe outcomes, greater incidence of intensive care, hospitalization, and unfortunately death. Next slide. So why do MAT? Why invest in that? So the first thing is that we have a large research base that says that it's safe. We've established that bupe is safe for use in pregnant women. It is approved for use for individuals over age 16. And what's really impressive in the data is that with bupe, you can demonstrate a 70% decrease in death from any cause, not just overdose, but any cause. A 70% decrease is a pretty significant return on investment for implementing that treatment. Next slide, please. It's cost effective. There are generic formulations available for almost all the medications. The other thing to consider is that we can reduce both the experience in terms of severity and the length of hospital stay for neonatal abstinence syndrome. The other really great return on investment is that we have multiple studies that show a decrease in drug use for people who receive MAT, as well as a decrease in drug-related crime. Next slide, please. One of the real difficulties, and those of you who have been involved in substance use disorder treatment, is that people relapse quickly. People also tend not to stick with treatment. And so one of the real impressive data is an 80 to 90% relapse without MAT, which the other side of that is people stay in treatment much longer and have less incidence of relapse. The other tremendous benefit is a reduced risk of infectious disease transmission. There are many different ways to take substances. Intravenous injection leads to a quick and more powerful effect compared to other methods of taking the drug. And unfortunately, shared needles can result in shared illnesses, in particular Hep C, HIV. And then the other slide showed you risk of overdose from any cause. Buprenorphine in particular shows a reduced risk of overdose from other opiates. Next slide. Perhaps one of the most impressive that I saw in terms of when I was administrating, the administrator of an MAT program is the dramatic increase in social functioning for folks, that you actually are able to get your life back. You're able to hold a job. If you recall that I mentioned withdrawal from an opiate can start 6 hours after taking the opiate, every 6 hours you're really fighting withdrawal. How do you work? How do you stay on the job for even a whole day if every 6 hours you're experiencing withdrawal again? And then being able to function as a parent, being able to focus, being able to be present, being able to be with your family is a tremendous benefit. There's also greater follow-up for treatment. So if you have started an MAT program or started inductions in your emergency department, good on you. And if you have the ability to progress and support that program, please do so. What we find out is that patients who initiate MAT through coming to the emergency department are 2 times more likely to remain or to participate in follow-up treatment. And again, for substance use disorder, keeping people in treatment is one of the hardest things to accomplish. Next slide, please. Next slide. There we go. So these findings are something that I'm very pleased about, because we were able to generate this information from our program. And the program that I was associated with was an outpatient-based program through an FQHC, and we had multiple sites, but all of them were in continue to be in very rural areas. Those of you who are psychopharmacology geeks may be aware of that kind of what's going on with these mu receptors, and is there an antidepressant effect that's associated with those mu effectors, and how we either block or what we do with them. And it turns out that there's a increasing body of information that says, yeah, it looks like there is. As part of the program that we had started and grew, we did routine assessments, routine screenings. Hopefully you all are aware of the PHQ-9 and the GAD-7. Those are respectively screenings for depression and for anxiety. And so we monitored our folks with those screening instruments. We administered those at every visit. And what we found is that 90% of our MAT patients showed an improvement. An improvement in this case is a reduction of either depressive symptoms or anxiety symptoms, or in some cases both. And what we specifically did was to screen at induction, and then we screened again after the first week of treatment. And what we found is, on average, we had almost a 60% to 59% improvement. And again, improvement is reduction of depressive and or anxiety related symptoms. Follow up over 3 months into treatment, and almost 74% of our folks, our MAT patients, experienced reduction in depressive and anxiety symptoms. And then that benefit seemed to continue, so that 6 months into treatment, 83% of the people receiving MAT services showed reductions in their depressive and anxiety related symptoms. That's a great return on investment. Next slide, please. So some common myths, and this is where I want to start speaking specifically about some of our experience. If you start an MAT program, every drug in, and I encourage people not to use disparaging terminology, but I put this in quotes because that's exactly what people said to us, are going to show up in your waiting room. They're going to be parked at your facility. That did not occur. What is reality is that our patients who don't on the surface appear to be whatever our fantasy or perhaps our fears of that street person, that stereotypical substance use disorder person who wanders the streets, who lives on the streets. That's not the population. Yes, substance use disorder occurs across socioeconomic status, across races, across gender, but the people who are already coming to you, many of those are experienced and or vulnerable to experiencing substance use disorder. So it really was the case that we can now offer another service, another treatment, and our goal was to treat the whole person to our existing patients. Yes, we got new patients, but I want to point out that you've already got patients who are experiencing substance use disorder. We did not have the waiting rooms filled. We did not have a sudden rush of everybody wanting to come in and get MAT treatment. We did have some interesting lessons. I'll share some of those. You will sometimes hear, especially from people who are kind of old school, chemical dependency, that you're just replacing one addiction with another. That myth is really reflecting a lack of understanding of the psychopharmacology, specifically of buprenorphine. And I'd be happy to do a presentation at depth, but people tend to get their eyes glazed over when I do my psychopharm geeking. And the one that really is discouraging is that MAT is a specialty treatment. That's somehow implying that we can't do that in primary care. And that's not at all true. It works, it has evidence base, and it is a very effective outpatient patient treatment. And primary care providers are very capable and able to do this. If you consider that people don't, or people have the best opportunity not to experience the negative effects of stigma by coming to a primary care provider, then just considering that if you can offer MAT, you've done a major accomplishment in terms of, okay, everybody in a small town knows who parks at that building, that community mental health center, or that specialty drug treatment program. So everybody comes to primary care at some point. Being able to offer this treatment in primary care is a major way to reduce the negative effects of stigma. Next slide, please. These were the questions that were submitted, so I'm going to give you answers based on our experience. There also is that the last slide is we are very fortunate to have an outstanding expert in Montana, Dr. Daniel Knotts. And with his permission, I've put his information up there for you. There are also resources in this state for waivered providers. There's an addiction medicine support group that's been formed. So you don't have to do this by yourself. You don't have to be alone out there. Lots and lots of resources. So if you need more information or you need more specific answers, Dr. Knotts is a wonderful resource. So low volumes, the heavy investment in time is during an induction. That can take, setting aside on average 3 to 4 hours. So just scheduling inductions, ideally on a Monday, and setting aside the time for that is one way to compensate for, yeah, we don't want to spend time tying up a primary care office and exam room, which are already at premiums in terms of use, for 3 to 4 hours to do an induction. Just having a comfortable room, not necessarily an exam room where someone can be comfortable, is actually recommended in doing inductions, especially for office-based inductions. And more inductions are being done at home. And now with some of the exemptions affording greater options for health services, there are things to explore there too. The low volume is also not a problem if you consider that you're doing this as part of your primary care services. So for example, that heavy time investment in an induction of 3 to 4 hours doesn't mean your provider is tied up for 3 to 4 hours. The process of induction is really utilizing the COWS, which is a opiate withdrawal scale, to determine the dosage rate that you're going to do. And someone had a specific question about that. So you have someone, the induction involves having someone in mild or maybe mild to moderate withdrawal, and then administering, in this case, buprenorphine is what I'm talking about specifically, or Suboxone ideally. And then checking where they are in terms of symptoms of withdrawal. That's what the COWS scale tells you, and then adjusting the dose or administering it according to the information you receive for that. So come in, start an initial dose, first start your assessment with the COWS, get a baseline, 30 minutes later, administer the COWS. And administering the COWS can be done by another staff member, preferably someone who doesn't need to have a specific license and graduate training to do those services, and then provide that information to your prescriber, to your provider. And in the meantime, the provider goes on with other scheduled patients, and that's kind of the biggest recommendation that I would give you in terms of the low volume, and that it's the inductions are the heavy investment of time. Routine MAT visits after the induction are like regular primary care visits. They don't have to be extended 40, 45-minute sessions. Then what's the reimbursement for the work? So that's determined by the payer. And the catch is that there's no catch. So the next part that I talk about is outpatient-based treatment is standard medical care, and the billing procedures that you use are the regular billing procedures, and I've listed some of them there. The reimbursement rates given there are a couple years old by now, and again, the reimbursement rate varies by payer, so please don't take those as accurate at this time. But the codes are the codes that are regular primary care codes. You still have the same E and M diagnosis in terms of complexity, and the relationship that a higher level of complexity has to reimbursement applies for MAT also. Next slide. So the prior authorization requirements, once you're a waivered provider, you can sign an attestation with Medicaid, and that eliminates prior approval processes for Suboxone. The other formulations, the other products do require PA in many instances. For example, Sublocade, which is the long-acting injectable form. Also, naltrexone X-ray requires prior approval. And as I mentioned in the previous slide, the commercial insurance, in the same way that the carriers determine reimbursement rate, they also vary in terms of their prior approval requirements. So the bottom line is you need to check with each. The Medicaid reimbursement schedules are published. Your reimbursement also can vary by your designation. For example, rural health clinic designations have a PPS rate. Next slide, please. This, how can I increase the support of the providers? This is where I wish I had my magic wand, because I don't have the best answer. So I've given some suggestions. One of the things that I find really helpful is to help our providers, and many of them get this, it's not rocket science, but substance use disorder is a chronic illness. And if you look at the work of primary care providers treat chronic illness. In Montana, especially, we have that bimodal distribution. We got kids, and we got old folks. And if you're somewhere in the middle, you may have a hard time living in Montana and finding a job. In rural areas in particular, there aren't many employment opportunities, so we tend to have an outmigration in our young adults. So your day-to-day bread and butter, if you're in a rural area in Montana, is, folks in my age, and the older you get, the more the likelihood of you qualifying for a chronic illness designation. So SUD is a chronic illness. Chronic illnesses are best treated through a team approach, and that's exactly what MAT is. As I mentioned previously, MAT is an outpatient patient service. Some folks have a high pucker factor about MAT using buprenorphine, but the evidence is just impressive. We have extensive experience, and as I mentioned, we have great support for our waivered providers in state, and many opportunities for training so that you can be comfortable with this. You can receive mentoring, you can receive academic detailing through Dr. Knotts. So you don't have to do this all by yourself and you're not out there all on your lonesome. And then the last point I want to emphasize is what do we want to do for our patients? And the wonderful opportunity in primary care is to treat the whole patient. And again, my soapbox is integrated treatment. And really, it's creating that team. So we can treat the whole person. And from the previous slides that I've shown, I think there's a convincing argument that, yep, uh, MAT is a good tool to have in your toolbox as a primary care provider. How do you help patients without insurance? Well, how many of your patients do you treat in other primary care services that you offer that don't have insurance? So many times it's existing policies or resources that you've already established. There are some specific programs. The Meadowlark program, for instance, has facilities participating in that. Meadowlark is specifically diagnosis and support for pregnant women with substance use disorder. And then also in Montana, we have a number of programs and facilities that have been supported through HRSA or SAMHSA grants. So if you don't have that support through your clinic or your center, referring patients, and I understand that we don't like to refer our patients out. We all want to do the best for all of our patients in-house. Sometimes our resources are limited. And these programs in particular offer support to those facilities to offer treatment to patients who do not have other resources available to them. And we can get you a list of programs throughout the state also if you just let us know if you don't already have access to that. Next slide, please. Dosing and frequency. So this information is covered extensively in the waiver training, and it essentially is guided by the CALs for your induction. If you have someone who's not currently dependent, as in someone just recently released from incarceration, then the general starting dose is 2 milligrams and you advance very slowly. If you have information that they have an ongoing dependence, then 4 milligrams would be the starting dose. The max daily dose for day 1, which is the induction, is between 8 to 16 milligrams. The max dose for the second day is 4 to 24. 24 is the max dose because you get maximum receptor occupancy. Around that area between 16 and 24 is when you start approaching that. So a higher dose doesn't do anything any different with, and this is looking at Suboxone in terms of the maximum dose. And then the documentation is really, your documentation is to establish an SUD diagnosis that's recognized as having support for treatment through MAT, and that would be most often your opiate use disorder or alcohol use disorder. One of the wrinkles that you want to be aware of if you're not is that buprenorphine is also used for pain as a pain medication, and that does not require a waiver for that. However, if you have a patient who's been receiving buprenorphine for the treatment of pain, then in Medicaid in particular, they're not going to approve use of buprenorphine for substance use disorder. So you want to be careful about it, again, establishing the substance use disorder diagnosis, and you may have to do a little additional documentation specifying that buprenorphine is not being used for pain treatment, that it's being used specifically for substance use disorder. And again, that circles back to having the waiver to use an opiate for the treatment of a substance use disorder. Next slide. And this is Dan, Dr. Dan's information. He is a member of the Drug Utilization Board for Mountain Pacific. There is a grant program that provides his services as an academic detailer. So you can sign up for that. And again, through that grant, the waiver training is offered for free. And in many cases, depending on the eligibility, his consultation as an academic detailer is available also. So I'd now like to take the time that we have. Hopefully I've answered some questions, but also that we can have a discussion or provide any additional information that you guys might want.
So this is where we count on you guys to give us some additional feedback or to share a good story. So I'm going to go ahead and start just to get the ice broken. We were working in Missoula on a community coalition and found that some of our ED patients that had overdosed and were taken to the ER were actually discharged and lost to follow-up. And through some conversations between partnership as with their integrated IMAP program and the ER docs, we actually had a telephone consult just like 2 days ago that was the ER doc used the 3-day rule. And I don't know what the correct term is, but I'm going to let Earl kind of talk about how even if you, I mean, obviously we want everybody to go through the free training that the Montana Primary Care Association has. But why don't you talk a little bit about that 3-day waiver that is kind of a back way for the ED to at least facilitate a transition of care to, a MAT waived provider.
Yeah, that's wonderful news. If you think about that slide that said that you really double the likelihood of someone following up with treatment after having induction started in the ED, that's a dramatic return on investment for that. So the short version is it's not a series of hurdles, a great big barrier to be able to start to do an induction in the ED. That's what the waiver is for. You can legitimately start it. They follow up with a waivered provider. And again, as I mentioned earlier, inductions aren't this specialty process that primary care providers are very effective in doing that, and the knowledge base is out there. So the other reason I really, really, really want to encourage people to do this is that it builds that bridge between the waivered providers, the MAT programs in the community, and the ED. And if you look at the data, what creates many problems for EDs, and it used to be a problem that we saw in primary care, it would be the Friday afternoon, usually in the last half hour, I need an early refill on my pain meds routine. And then you have people coming to your ER because they lost their pain meds, et cetera, et cetera. And what happens is people are chasing withdrawal, and you don't want to go into withdrawal. So whatever keeps you from doing that has a high value to you. We found that we had a decrease in our folks losing their pain meds, and it took a while. So what we found is that we had, and word on the street goes fast, we didn't have every quote druggie showing up, but we had a lot of people who had been fired from their pain treatment provider who wanted to come when they heard that we were doing MAT services. And we were very specific and upfront and specified that this is an MAT program. It is not a pain treatment program. And we had a bunch of people get very offended, saying that we were somehow labeling them as something. And they left unhappy. And for many of them, 6 weeks later, they came again and saying that, yeah, okay, they appreciated the information and acknowledging that, yes, they believe they had a substance use disorder and wanted some help for that. As I said, that took about 6 weeks. It wasn't upfront. But then once those people are in treatment, we don't have the incentive, primarily because they're not experiencing withdrawal. The beauty of Suboxone is that it has a protective factor, that you don't experience withdrawal. You can be functional. You're at a steady state in terms of the neurophysiology, and that ultimately reduces that chase the meds, stop withdrawal, that we have for many people who have, yes, legitimate pain, but have crossed over into a substance use disorder with, in this case, prescription opiates. So everybody benefits, the community, the partnership from the ED and that, but it really over time stops that coming into the ER or coming into primary care wanting early refills or all the things that we suffered through with I am not getting the right treatment and you owe me my pain meds.
Yes, I'm sure that there are a lot of ER physicians that have experienced that same thing. Also, I mean, I think to your point too about the decrease in potential infections is huge. You know, that's another kind of return on investment that is.
How many times do you get the opportunity to do harm reduction, effective treatment, increase the probability of continuing treatment, and stop that cycle of chasing withdrawal all at the same time? Um, that's a wonderful opportunity. And primary care providers don't go into primary care because they expect to get rich. They go into primary care because they want to treat their folks and they want to do the best they can for them. And this is a wonderful tool that increases what we can do to help our primary care patients.
So I'd like to open it again to the audience to see if you have other comments or questions. So feel free to just chat at me real quick and I'll unmute you, or Maynette will, our fearless operator. But in the meantime, I'm going to ask another one because I always have a gazillion questions. So can you talk a little bit about if like an integrated behavioral health program is, you know, optimal or helpful, or what's the prescribing piece, the medication piece versus the head piece?
Thank you. I love invitations to climb on my soapbox. So, and I want to give a little clarification. Integrated behavioral health can be done even if you don't have a licensed behavioral health provider. There are interventions, there are many things that we can do and we can teach folks to do that provide services in that behavioral health continuum. So a lot of folks think that if I don't have a behavioral health provider, I can't do this. But what it really focuses on is having a team. So in the case of MAT, you're not likely to have a big rush of people during induction signing up for follow-up behavioral health treatment. Uh, Again, induction begins with being in withdrawal. And yeah, you're not warm and fuzzy in terms of your outlook about the world and everyone around you. But what we've seen, and that was why I put that data up there, is that people start feeling better. And I think there is something to this buprenorphine and an antidepressant effect. And when they feel better, their concentration improves, and then they become amenable. So what we did is we offered information, and then we also did follow-up, just checking in. How are you doing? How are things going? We tell people up front that it's a team program, and we introduce them to all the team members. Things don't really get stored in long-term memory when you're experiencing withdrawal, so we remind them and give them information that lists their team, and we tell them the team members are going to check up on you. And then we offer services with a specific goal. So people may say, I I actually now recognize that I have some relationship problems that yeah, I kind of didn't want to pay attention to before. One of the things we also did was to offer a wellness group, which offered um, behavioral techniques to cope with pain. Many people legitimately start with an injury, with a chronic pain that yeah, that's still there. So we give them other resources for that, and all of that becomes doable with a team.
Awesome. I got a couple more for you, Earl.
Okie doke.
Robin is added as a panelist, and she asks, Robelin, I'm probably butchering your name. I'm sorry. Just to clarify, providers who undergo the MAT training can prescribe Suboxone in an outpatient clinic. I do believe there's a couple of other steps. Do you want to talk about what those are?
Um, yeah, so the X waiver necessitating the 24/7 availability.
Oh yeah, and that's from Dr. Hansen.
Oh, okay. Um, I'm not aware of that. Uh, and I could be wrong. Dan, Dr. Knotts is the expert. What um, we kind of address that in terms of the structure of our program. And what happens is in induction, you want to have follow-up. So the second day is having people back. And then as part of that, we had a whole policy and a procedure about, okay, how to get your medications. One of the things I want to mention is the assessment scale out of Oregon. So in increasing the dose um, in MAT is really a form of risk assessment. Can you trust people with 2 weeks worth of their medication? How do you know to do that? Can you trust them with a month? And so the process is for the first 2 weeks in particular, you keep close control of doses and you have that outlined in your procedure. So having someone lose their dose or something, generally you're dealing with that in your program procedures and policies. Um, and then controlling do you come back to get your third day's worth of medication, or do you give them 72 hours worth of medication? So that tends to minimize the need for I lost my meds or something's going on. But again, I'm not aware of that requirement. I could be wrong about that. Dr. Dan, Dr. Knotts would have uh, the actual information on that. There are also some well, that gets into technical. So some of the formulations don't lend themselves to abuse as much. So there are a number of options if that is a requirement too. Some I'm scrolling down now. Okay. Yes, there are additional hours. Physicians have the 8-hour requirement, and then there are the additional hours for a advanced practice nurse and physician's assistants. And all of those are available for free too, in some form or fashion.
And like I said in the chat box, I will provide some additional flyers and things like that to everybody that registered for this webinar. So look for that as well. You will also receive copies of the recording of today, as well as the slide deck. So that should be available for you as well. So I think we have like 1 minute to spare. Any other last pearls of wisdom other than do it? I will add one more thing. There are some additional grant funds that are available from the state for those of you that are interested in working with patients with stimulant use disorders. And that RFP is out on the website, and the state is also putting together a resource for addressing medication-assisted treatment in the ED. So it's not out yet, but it's gonna come out one of these days. So it's a good time to prepare and think of what you can do to help this population. So with that, I'll let everybody go and have a great evening. Bye-bye.